few areas. We're going to kind of discuss just general diseases. They don't necessarily all tie into each other because we got like RA, we got GI stuff, we got asthma. So we kind of, in COPD, so we kind of talk about a few things here. We will have a review today, probably about a little over an hour. We got about 44 slides to talk through for the Unit 5 information. Please make sure that you turn in your drug cards and that you do your case study. The case study is going to help reiterate some of the information that is needed to be successful on your final, along with understanding the information that is in Unit 5. So when we look at Unit 5, the drugs for therapy for RA, RA is basically you're looking at the stiffness of the joints. For those of you that have seen people, their fingers kind of get the swan-like neck, cramping, like their hands are crampy constantly and they can't straighten out their joints. So treatment that is non-drug measures, which we refer to as non-pharmacological, looking at ways of doing different things besides using drugs. Heat, massage, warm baths, physical therapy can help patients become that true stiffness, like the swan neck. Exercising and surgery is one of those things that's an option for patients with RA, but typically not a go-to first thing that you do. When you look at the 3 drug categories, they'll be used at different stages for the disease for each patient. So patients typically start out and are well controlled with your NSAIDs, so your anti-inflammatories medication, and then some will progress to taking the disease-modifying antiarrhythmic drugs, or rheumatic meds, anti-rheumatic medications. And then sometimes when they have flare-ups or short-term use, they'll use the glucose corticoids. So you will see throughout your careers that people at different stages use different type of medications for certain things. When we look at the corticoids, remember, used for short-term use, okay? Long-term use can result in patients having problems with osteoporosis, gastric ulcers, adrenal suppression. So we want to make sure that patients understand that prednisone is used for short-term only. Usually patients for RA purposes use the glucose corticoid steroids as a way of building up, using it as a short-term use while they're building up their therapeutic effects with the methotrexate, the other type of medication that they use to treat RA long-term. When you look at your DMARDs, your disease-modifying anti-rheumatic drugs, you're looking at non-biological and biological. So methotrexate is the first one that's most common, and it's due because it's a low cost effective therapy, and that's why it is used to treat RA, and it's a relatively safe medication. However, it does have its toxicity. It can be harmful to a body, which most medications, like even your Tylenol, can be harmful to the body. So toxicities that you see in your methotrexate are going to be liver problems, bone marrow suppression, GI ulcers, and even types of pneumonia can occur. So when you look at your labs, you're monitoring your CBC, you're monitoring your kidney functions, you're monitoring your liver functions. When you have patients taking medications and you need to monitor drug levels or, CBCs or kidney functions or liver functions, those things are important for you to look at when you're administering these medications. Because if someone is critical in their lab results, you may not want to give them that medication to make their matters worse. So you need to make sure that you understand why we check our lab values, because it's important. Because we don't want to give someone a dose of a medication that's going to cause more harm to their liver, and boom, all of a sudden they're in liver failure, in need of an emergency transplant, which doesn't occur very often, and the patient ends up actually passing away. So make sure that you do pay attention to your lab values, because they do play an important role in whether we give a medication or whether we hold a medication. When you look at some of the biologic agents that you see, you got the tumor necrosis factor, you got the B lymphocytes, you got the T cells. So you got those different types. The one that you probably recognize the most is going to be the tumor necrosis factor, based off of the fact that this is one of the more common medications that you will see. It's used only with your high-risk patients. It's IV or sub-Q given, so you're going to teach your patients how to give sub-Q medication, and teach them about infection, because again, when they start to have signs and symptoms of infections, they may need to stop taking this medication. They also need to be taught how to assess heart failure, because this medication can cause patients to have a new onset of heart failure, congestive heart failure, or can actually cause a exacerbation of their current CHF. And again, at risk for liver disease and hematological diseases. Enbrel is probably the most common one out there that you will see for a tumor necrosis factor antagonist medication. The Enbrel is used to treat the moderate to severe. Again, you're going to see the heart failure possibility of the blood disorders, the hematological disorders. Drug-to-drug interactions with your Enbrel, they interact with live vaccination. So a live vaccination means that you're actually receiving your vaccination you're receiving is actually a live dose of that vaccine. So those aren't as common as they used to be. Now a lot of our vaccinations are like synthetic, so they're made up and they're not live anymore. Immunosuppressant medications such as your glucocorticoids don't mix with the Enbrel, with the tumor necrosis factor antagonist. So you want to make sure that you are making sure that the patients aren't on them. That's another reason why the methotrexate is the preferred one, because you can take the methotrexate with the glucocorticoids as you are building up the therapeutic level for the patient. When we look at gout, gout is a recurrent inflammation disorder that characterized by your hyperuricemia, which is high levels of uric acid in the blood. So when you're looking at how it acts, it has that excessive production of uric acid, and it impairs renal excretion of the uric acid, so patients retain it. It's like when you look at it, when we draw fluid off of a joint and you look at it, it looks like crystals in the microscope. So drug therapy is given short-term to relieve symptoms for an acute attack, and long-term to help keep blood levels low. So drugs that are used to treat gout are going to be your NSAIDs, your glucocorticoids, and your cholecystinians. So when we look at the different types, your NSAIDs, Your Indocin is a prescription. Your naproxen, your naproxen is one you can buy over the counter. When you look at adverse effects of your NSAIDs, you're basically looking at like GI upset, your impaired renal functions, fluid restrictions, your increased risk of cardiovascular events can occur when you have someone who is on repetitive doses of NSAIDs. When you look at your glucose corticoids, again, short-term use, prednisone is probably your most common. Adverse effects, remember, using prednisone for, and when I say short-term, we're looking like a few months of treatment, possibly. You're looking at patients can have that even a 2-week time frame can have high glycemia. So their blood sugars need to be monitored, especially if they're a diabetic. That way they do change over their insulin dose if they need to, that they do adjust it. When you look at the cholecystine, you're looking at that being an anti-inflammatory that's prescription, used for short-term for acute attacks, but then also is given to patients long-term to help prevent attacks. When you look at your adverse effects of this medication, what we're looking at is the fact that we're going to have some GI issues. We're going to have possibly some bone marrow functions that are affected. Patients might end up with leukopenia. They might have thrombocytopenia. So again, we want to monitor their lab values, their complete blood count, their CBC. You also see rhabdomyolysis in patients. So with those patients, you're monitoring like CPK and you're looking at their lactic acid. So there are different lab values that help determine whether or not it is safe for us to give a medication. When we look at the drug-to-drug interactions with this group of meds, your statins that we take for cholesterol lowering medications, they interact by causing an increased risk of muscle injury. So that rhabdomyolysis is more common when you're combining those two medications. Another type of medication that is used to treat gout is allopurinol. That is used to treat chronic gout. That is a common medication. You actually will see that it is given to patients who need a small treatment plan. So you will see that biggest adverse effect to this one can be a fatal hypersensitivity syndrome. And what you're going to see is they have eosinophil issues, which is your part of your white blood cell. They have a fever and rash, and they have a dysfunction of their liver and kidneys. So their liver and kidneys basically shut down. When you look at the drug-to-drug interactions, the medications that cause problems with this medication are going to be Coumadin, theophylline, and then ampicillin. And then this is just another medication that is used to treat gout. It acts, basically your mechanism of action for this medication is that it acts on your renal tubulars. So it inhibits reabsorption of the uric acid, which means you pee it out then because the renal functions are not reabsorbing it back into the body. The mild problems with the adverse effects are mild. It's your general GI, nausea and vomiting, and drug-to-drug interaction is going to be with aspirin. When we get into the drugs affecting calcium levels and bone mineralization, you are looking at different diseases here. So these conditions are all treated basically due to calcium issues in the bloodstream, whether it's caused by having a decrease of calcium or an increase of calcium, or having issues with the parathyroid. So hypercalcemia is usually asymptomatic. Your patients usually don't show any symptoms of having a high level of calcium until they have damage to their kidneys. So you're seeing the increase in urination, nighttime urination. You also are seeing they have nausea, vomiting, and constipation. You're also going to see that they have depression, or they're lethargic, so they'll have central nervous system changes. So hypercalcemia takes a while before you actually know that that's possibly a problem for your patient. Causes for hypercalcemia can be the fact of having a cancer of some sort, or having a hyperparathyroidism can be a reason for hypercalcemia. Treatment is going to be replacing fluids with IV solution, and using a loop diuretic kind of helps push out all those extra minerals. So again, want to monitor your labs, glucose corticoids, so your steroids, and then your biphosphonates are going to be, that's your phosphate medications. Phosphate attaches to calcium. So it's going to help excrete those extra high levels of calcium in the body. When you look at hypocalcemia, you're looking at an increase in neuromuscular excitement. So it's going to be caused by problems. Sorry about that. It's going to be caused by problems in the parathyroid again, deficiency in vitamin D or your dietary calcium, can be caused by chronic renal failure, your hypocalcemia, and it can actually be caused by long-term use of your magnesium-based laxatives that we'll kind of talk about somewhat today. So treatment for your hypocalcemia is going to be long-term use of calcium and vitamin D, because you want to make sure that the calcium is absorbed. Yes, we have calcium in our foods and stuff and we eat it, but vitamin D with an oral tablet of calcium is better absorbed. So a lot of times patients need to know that if they don't buy a calcium with vitamin D tablet, that they need to buy both the calcium and the vitamin D. Because when taking PO, it doesn't absorb as well as a tablet without that vitamin D in the system. When you look at osteomyelitis and rickets, those are both related to having an insufficiency of vitamin D or limited exposure to sunlight. Osteoporosis, as we know, is a decrease in calcium resulting in bone loss, which increases bone being fragile. Your Paget's disease is basically found in the spine, skull, and tibia, actually. It's an alteration in bone homeostasis. Treatment for that is basically treat the pain with your NSAIDs and other pain medications. You're going to see your hypoparathyroidism is due to a decreased amount of the parathyroid hormone, usually as a result of having the parathyroid gland removed. When you look at this, patients are going to have symptoms such as tetany, the skeletal muscle spasms, laryngeal spasms, or convulsions. And then you have your hyperparathyroidism, which is going to be basically a result of having a benign anadoma, which is like a tumor, caused by causes muscle weaknesses, constipation, lethargy, and depression. However, hyperparathyroidism can be caused by a secondary thing, such as issues with the kidneys. And usually when the kidneys start to fail, patients who have problems with the parathyroidism, then having hyperparathyroidism, usually can be managed with taking a phosphate binding agent such as Foslo. when we look at how we treat some of these disorders that are related to calcium levels and bone mineralization, calcium salts are used to treat your hypocalcemia patients. So your Foslo, Tums, Rolaids, Citracal, calcium gluconate, those are all oral medications that can be given to patients to treat what's going on. So usually drug interactions with these medications are going to be your glucose corticoids, which lead to a reduction of absorption of calcium, resulting in osteoporosis. Phenytoin, thyroid hormones, tetracyclines can reduce the amount of calcium being absorbed. Sorry, reverse that. Calcium will reduce the amount of those drugs being absorbed. So it's important that they do not take them at the same time as they are taking the calcium tablets, the Tums and stuff. So that's an important reason on why night shift needs to be giving the levothyroxine before they leave, so that when the nurses come in at 9 o'clock, 8:30, 9 o'clock, and give them their morning doses of meds, that the levothyroxine has already been digested through the system and won't be wasted. When you look at your loop diuretics, they actually can cause hypocalcemia, so it might make their hypocalcemia worse, versus your thiazide diuretic actually can cause hypercalcemia. Foods that are, do carry some calcium or drug-to-drug interactions that can suppress calcium absorption are going to be like your spinach, rhubarb, Swiss chard, beets, all kind of things that most people don't eat anyways. But you also have whole grain cereal and bran that kind of interact also with calcium absorption. When you look at parental types of calcium salts that are used to treat hypocalcemia, you're looking at calcium gluconate and calcium chloride. Those are two medications given IV to raise a calcium level. I'll say rapidly, not immediately. Rapidly. The problem with giving these two medications is the recommendation route is IV, because the calcium gluconate and the calcium chloride can cause sloughing and necrosis of the skin if given IM. So meaning that you're going to really cause an injury to your patients if you ever give it IM. However, you also need to take into consideration the vein. Your IV site needs to be an appropriate vein, because you are looking at the fact of it being hard on the veins also. So you can't take that little vein you see in the person's knuckle on their index finger and push calcium gluconate through that. You will cause them pain and discomfort and possibly infection of sloughing and necrosis of that area of their hand. So IVs typically nice size, higher up they are, the better off you are with giving that medication. When you are looking at overdose on it, you're going to see signs and symptoms of hypercalcemia. So remember, we go from hypo to hyper when we're looking for signs and symptoms. So signs and symptoms of patients who have hypercalcemia, because they received too much calcium and now they've overdosed, they're going to have weakness, lethargy, nausea, vomiting, coma, and it can possibly even kill your patient, because your calcium is, when given rapidly or given excessively, can throw off the heart muscles, which puts them into an irregular rhythm, which causes cardiac arrest. When you look at vitamin D, You look at the fact that it's essential for your bone health. Okay. So vitamin D, you have vitamin D2, you have vitamin D3. So you see the different types out there. When it's accidentally ingested too much of it, that's where you get the hypervitamous D. Um, Usually patients are going to present with weakness, fatigue, and nausea, vomiting, constipation. I mean, treatment is simple. Yes, stop the vitamin D. You reduce their calcium intake because, as we know, vitamin D and calcium work well together. And you increase their fluid intake, so they pee out this extra vitamin D that they have. And sometimes they do treat it with your glucose corticoids. When we look at calcitonin, 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 excuse me, thank you. You have a decrease in bone absorption, increase in calcium excretion, used to treat your hypercalcemia, your Paget's disease, and osteoporosis. So can be given IM, sub-Q, or intranasal, so nasal spray up the nose. When you look at using it as a nasal spray, you're looking at possible irritation in the nasal cavity there and dryness. When given IM or sub-Q, you can have patients who complain of having that flushing of their face or hands, that warmth while giving the medication, or possibly nausea feeling after receiving the medication. Let's take a 5-minute break here, guys. Adverse effects are going to be similar to each other type of medication in this group, that is such as your Bonavia, Reclass, and Actinol. They all have nausea, vomiting as most common adverse effect that occurs. When you look at the mechanism of action for Fosamax, you're basically looking at it suppressing bone reabsorption. It's used in treatment for Paget's disease and osteoporosis, both in men and women. Adverse effects that can occur specific to the Fosamax is esophagitis, atypical femoral fractures, so fractures that just occur in their legs with no injury, or the esophageal issue is due to the fact that the stomach acid and the medication goes back up into the esophagus, resulting in the patient having an infection in their esophagus because it breaks down the lining. So proper administration of these medications is important. When you're looking at that, it should be a full glass of water. The patient needs to remain upright after taking the medication for about 30 minutes after dosing. So sitting up in their bed, sitting up in a chair, up and being mobile. They should take it on an empty stomach. So again, a couple hours before breakfast, and they should avoid chewing or sucking on the tablet. They should actually just swallow it immediately, because you don't want even though the digestive process starts the minute you put something to your lips, you don't want the tablet to be dissolved any bit in the mouth and then goes down the esophagus, causing the issue in the esophagus. When we look at asthma, we're looking at a chronic inflammatory disorder, airway inflammation resulting from an immune response known to be an allergen. So you have different classifications. So there's intermediate, there's mild, there's moderate, and there's severe. Most people can manage their asthma well. if they manage their other issues, such as allergies. So prevention and goals is to maintain their airway so that they can function by treating the symptoms, using a short-term inhaler, short-acting inhaler if need be for rescues with less than 2 days per week, maintaining near or normal near pulmonary function. So yearly they should follow up with their ear, nose, and throat doctor or their pulmonologist to our allergist to make sure that they have their airway, have a pulmonary function test done to make sure that they are functioning well. They should work on managing their symptoms so that they can physically exercise and not have the activity induced asthma reactions that they get. And they should actually educate family members and loved ones on how to use all of the devices, such as the inhaler, the spacer, the incentive spirometer, and all those things so that they can manage their asthma. When you look at COPD, looking at the result of patient having bronchitis and emphysema for a period of time repetitively, usually a COPD patient, you're going to be able to tell they have the difficulty breathing. They sit in that tripod position where they got their elbows resting on their knees and they're leaning forward to try and breathe. You'll have mild, moderate, severe, and very severe. As far as your classifications, you want to make sure that you reduce symptoms by improving the patient's health status and exercise tolerance. The overall goal is to reduce the risk and mortality by preventing progression of their COPD and by preventing and managing any exacerbations that they may have with COPD. So you do have patients who have very few risks for symptoms, and then you have group D, which would be an increased high risk. So kind of like your mild to severe to mild to very severe types groups, depending on what their symptoms are and how severe their symptoms are. So when we look at the definitions of bronchitis and emphysema, we're looking at bronchitis being chronic cough and excessive sputum production. And then we look at emphysema as an enlargement of the airspace with the bronchioles and the alveoli brought on by deterioration of the walls of those air spaces. So you will see that patients can COPD patients are diagnosed by the fact that they have both bronchitis and emphysema, but you can have patients who aren't labeled COPDers, but do have emphysema or do have bronchitis. When you look at your treatment of drugs, these are your classifications. When we look at devices, we have the different types of inhalers. So when you look at a meter dose inhaler, that's the one that you use the spacer with, that you shake up, take a deep breath in and out, and then have the patient put the spacer in their mouth, and you press down and have them inhale that dose. Your wrist mats are the inhalers that deliver at a defined miss, and so that you actually don't need to use a spacer with. The advantages is that it's extremely small particles that ensure the delivery of the drug into the lung versus the back of the throat where a lot of the things hit. Then you have the dried powder inhalers, which again also is a small amount of particles that actually is a powder that's directly inhaled. You again don't use spacers with this dry powdered inhalers. So when you look at your Advair disc, that would be an example of this. Nebulizers are your liquid medications that are put into a mouth like a mist, and so they kind of inhale the mist. You want to make sure that patients who are utilizing any inhalers get them in the habit of rinsing their mouth out after they use an inhaler, just because some medications are increase the patient's risk for yeast infections. Please make sure that you watch the YouTube video in this PowerPoint, and also that on the Aid to Success that you do look at that one also. When you look at your corticoids, your steroids, again, going back into your prednisone, is the oral one that is used a lot. Your inhalers that have steroids in them are going to be your Aerobid, Flovent, Pulmicort. Those are all common names of inhalers that have the steroid in them. So the mechanism of action is to decrease the asthmatic symptoms by suppressing inflammation, decrease the synthesis and release of inflammatory mediators such as histamines. And then you look at the decrease of infiltration and activity of cells such as your leukocytes that increase inflammation. And then you look at the decrease of edema of the airway and the mucosas. When let me go back. When you look at the adverse effects, again, oral pharyngeal candidinitis, so yeast infection in the oral pharynx, is a side effect that is very painful and discomforting for patients. It's very sometimes takes a long time to treat, to clear up. During that time, patients have pain with swallowing. They really don't eat a whole lot because they can't swallow past, it hurts to swallow past that yeast infection. You also can see that they have hoarseness to their voice, speaking difficulties. In children, it can slow their growth. Adrenal suppression can occur with patients using the glucose corticoid steroids. Long-term use, again, remember, promotes the vitamin D calcium loss, which increases their risk for osteoporosis. And then also we had the long-term use also creates the cataracts and glaucoma. Cromolyn is another medication that is used to treat asthma. It suppresses the inflammation, but it does not cause the bronchodilation. It is administered a lot of times with a nebulizer. When you look at your bronchodilators, your beta-2 adrenergic antagonists, you are looking at the fact of they provide symptomatic relief in patients with asthma and COPD, but they don't alter the underlying inflammation that is part of the disease process. So they work in the smooth muscles of the lung, and they relieve that bronchial spasm. So this is going to be your short-term inhalers is like your rescue inhalers, like your albuterol that you're using. When you have patients that are taking these inhalers, too much of a bronchodilator, you see it more so when you're doing like the nebulizer treatments, or patients who are just puffing a lot on their albuterol inhalers. You're going to see that they have that heart rate increase, that they get antsy, that they feel fidgety, makes their breathing worse because, they can feel their heart racing. But worst case scenario, you can have cardiac arrest because you have that increase in heart rate, which can result in a dysrhythmia. So you want to make sure that patients who are utilizing the inhalers as a rescue inhaler that they understand that they can't just use it and use it and use it, because they're going to put their heart into a possible irregular rhythm. So, a list here of some of your short-term, long-term acting inhalers. And you will see there are combinations of certain different inhalers out there too. So, another medication used to treat asthma and COPD is going to be the methoxyzine thins. So they produce bronchodilation by relaxing smooth muscles of the bronchi. It can be drug interactions can be due to caffeine intake, smoking, marijuana. They don't interact well. Drugs that reduce the level of theophylline or the aminophylline in the blood are going to be your phenobarbital and your phenatone. When you look at drugs that increase the medication here, that's going to be your fluoroquines and your Tegament. When you look at toxicity of this drug, you're basically looking at the patient having nervousness, restlessness, insomnia, nausea, vomiting, and diarrhea. You also get the irregular heart rhythm, so you could have some cardiac issues, along with being that it's a breathing issue too. You're going to have cardiorespiratory issues. So when you look at treatment, a lot of times they give your activated charcoal or lidocaine and diazepam for treating the possible irregular heart rhythms and to help with the restlessness and settle the patient down. When you look at the leukotriene modifiers, these are going to be your Singulair, your Zyflow medication. So the mechanism of action here is the fact that it suppresses the effects of the leukotrienes, which are components that promote smooth muscle constriction and help in the inflammatory response. So it decreases bronchoconstriction in inflammatory responses. So it helps patients' airways open up. When you look at your anticholinergic drugs, most common one there is listed is your ipratropium. It is a atropine derivative, which is administered by inhaling it, and it relieves your bronchospasms. It's also known as Atrovent, but when you look at it in combinations, like in the DuoNeb, which is the nebulizer that patients receive, or in Combivent when it is combined with the albuterol. So this is where you see the combination of albuterol with it. So it's a short acting and kind of a longer acting medication. When we look at colds themselves and allergies, basically looking at someone who has allergies, they have sneezing, they have nasal congestion, they have itching, they have rhinorrhea, so running of the nose, so water, sinus drainage. When you look at the drug classifications, you have your glucocorticoids again, which typically are in intranasal medications, your antihistamines, which are oral or intranasal medications. And then you have the sympathomedics, oral and intranasal types of medications. So when we look at peptic ulcers, we're basically looking at the fact of having the major defense factors are the mucus and the biocarbonates. The aggressive factors are being your H. pylori and your non-steroidal anti-inflammatory drugs. So your NSAIDs are affecting this, what happens is they develop where there is an imbalance between the mucosal defense factors and the aggressive factors. So what happens is patients end up with an ulcer in their stomach lining, and the goal and treatment of that is to alleviate symptoms, help promote the healing. When it's an H. pylori factor, you treat with antibiotics. When it is an NSAID problem, you stop taking the NSAIDs. When you look at treatment with the H. pylori, you're looking at the multiple different types of antibiotics that are used. The main focus on educating your patients with H. pylori treatment is the fact when they're taking these antibiotics, they will have possibility of what we say explosive diarrhea. So they need to make sure that they are doing their treatments at home and taking these medications. And I know most patients take it for 10 to 14 days, and to say you're going to miss 10 to 14 days of work to take this type of treatment is, I know, not realistic always. However, patients will have explosive diarrhea, so it is important that they understand that. When you look at your histamines, 2 receptor antagonists, so things that are going to suppress your gastric acid. Tegament is one, Zantac is another one. However, due to research, Zantac is no longer available on the market due to the fact that it increases the risk of cancer when it sits longer term on a shelf or in a cupboard in someone's home, and it's exposed to the heat or the sunlight. It breaks down the tablet itself, releasing what appears to be chemicals that can cause cancer. So Zantac was pulled off of the market about a year ago and is no longer available. But when you look at your histamine 2s, you have your histamine 1s, which are your medications we take for like allergies. So treat the upper respiratory type of allergic reactions. Your histamine 2s also help in work on fighting off like an allergic reaction. So when you have a patient that might have an allergic reaction, you might be giving them an antihistamine 2 and an antihistamine 1 to help with their allergic reaction. When we look at our proton pump inhibitors, we are looking at suppressing gastric acid secretions. So patients who are using your proton pump inhibitors are receiving like Prilosec, Nexium, Protonix is probably the biggest one you will give. Protonix, we do Protonix drips for our GI bleed patients. So patients who are have a bleed somewhere in their GI, we want to basically shut off their gastric juices from happening so that we can settle their stomachs and stop the bleeding. When you look at adverse effects, patients who take regularly proton pump inhibitors can have what we call a rebound acid hypersecretion. So once they stop taking the proton pump inhibitor, they actually have this rebound of excessive gastric secretion. So that is not uncommon. Long-term use of your proton pump inhibitors actually can result in fractures from having osteoporosis. Hypomagnesium is another adverse effect that you can see in patients who take proton inhibitors. And as we know, magnesium, calcium, all those kind of work together. So vitamin D with the bones and stuff. So if they're having issues with low levels of magnesium, it's increasing their risk also for those fractures. When we look at laxatives, we look at the different kinds here. The first one being the bulk forming and you want to make sure that you review these. Your bulk forming mechanism of action is that there is that swell of water to form a viscous solution or gel. And so as you give the patient the Metamucil, we know we mix that in orange juice or water and it kind of looks slimy, like slime, or a gel like. It will soften the stool mass that is there. So we're using this to help with constipation is another reason we use it. And it increases its bulk. So it allows for that stool to softly move through the digestive tract, the intestines. So besides constipation, um, patients who have diverticulosis or irritable bowel constipation will use it. Sometimes patients who have, or not, sorry, irritable bowel syndrome with diarrhea will use it. Patients who have diarrhea will also use it to help form their stool more. And then patients who have an ileostomy or a colostomy may take Metamucil to help thicken their stools that are coming out of their colostomy or ileostomy. When you look at your adverse effects and your patient teaching for this medication, you want to make sure that patients are taking this medication with a full glass of water too. Because what happens is they can end up with an esophageal obstruction because the Metamucil starts to gel in the esophagus. So it's important that patients do take this medication with appropriate amount of fluid. And sometimes they take too much, which can result in also an intestinal obstruction or impactment due to it bulking up too much. When you look at the next two groups, surfactant and stimulant, you have the surfactant, which lowers surface tension, which facilitates penetration of fluid into the feces. You're going to see that it comes in forms of capsules, tablets, syrups, and liquids. Your most common one is going to be your Ducacet sodium. That's the gel. Usually you see it in a gel capsule is how it's given. You should take that also with a full glass of water. When you look at the stimulant laxatives, that stimulates the intestinal tract, and it also increases the amount of water and electrolytes into the intestinal tract. So basically those drugs that you're seeing there is your Senna is your biggest one probably that you will see. And a lot of times you will see that patients will take a Senna and Ducacet together. There is the combination of the medication that patients are prescribed to help really ensure that they are having regular bowel movements. Castor oil is a very powerful stimulant laxative. It's not routinely used, but if it is, you want to make sure that you're not giving it to a patient at bedtime because they will be up all night pooping. When you look at your osmotics laxatives, you're looking at the fact that it draws water into the intestinal tract and it's to empty the bowels, and use of it is usually to empty the bowels in preparation for like a surgical procedure or a diagnostic testing such as a colonoscopy. The problem is it can cause dehydration and can cause hypertension, edema, and can exacerbate someone's heart failure because of the shift of fluids. When you look at the types that are out there, laxative salts are out there. You have your lactulose, and then you have your Miralax. Lactulose is like a sugar, so it is poorly absorbed in the intestines. So it helps lower ammonia levels in a patient because when patients have cirrhosis of their liver, you're going to see that they have a high level of ammonium in their bloodstream, and you will give them a lactulose to drink, and it will decrease their levels of ammonia because they are actually just peeing it, they're or pooping it out. Sadly enough, we do have patients that abuse laxatives of all ages. Your elderly population, they abuse it because they don't want constipation, so they want to poop all the time. And then your younger generations, they want to take the laxative, so they poop all the time and don't put on any weight. So you want to make sure that you do talk to people about proper use of laxatives, and that chronic exposure to a laxative can diminish their reflexes for actually having a normal stool. So it can lead to requiring the reliance on having to use a laxative for life. Treatment, again, if you have someone who's abusing it, you want to cease the use of laxatives. You want to instruct them on how to regulate their bowels by eating high fiber foods, increasing their oral intake of water, daily exercising. Okay. So when we look at another type of medication, we're talking antiemetic drugs. These medications are used to treat nausea and vomiting. Your most common one in this group for your serotonin receptor and antagonist is going to be your ondansetron, which is your Zofran. Zofran it's a nausea medication, so you want to make sure your patients understand if they're nauseous, they should take the medication and not wait till they're actively vomiting to take the medication, because it will be more effective when they take it when they're nauseated. Morning sickness, nausea from anesthesia, viral infections such as your GI bug is reasons why we give patients Zofran. Another thing as a nurse that we want to make sure we understand is patients who are being treated for cancer. Chemotherapy drugs are very hard on the system, so we want to make sure that we are taking the time before we start their chemo medications and give them some Zofran to help settle their nausea that's going to occur with their medication. When we look at other types of medications that we use to treat nausea, lorazepam, Ativan is one medication that you can see patients are using to treat their nausea. Dopamine anti-antagonists such as Reglan and Phenergan are another two types of antiemetic drugs that are being used to treat nausea and vomiting. When we look at motion sickness, okay, so that's what we see with people who get nausea, vomiting, cold sweats, the pale feeling, the pale skin due to riding in a car, flying, right, being on a boat, and even space travel can cause motion sickness. So treating it with antihistamines is one way. Your meclizine is a treatment for motion sickness. And then there is a patch that patients can wear behind their ears. It is a common place where they put it, and that is scopolamine patches is where, and those can be all over the counter medications. You can get prescriptions for both, but you can buy both over the counter. Both of these medications, the side effects are going to be your dry mouth, your blurred vision, drowsiness, because constipation, urinary tension, you will see. But both of these medications work by mechanism of action of inhibiting nerves from the inner ear to the vomiting center. So it kind of shuts off that inner ear to the vomiting center and allows for the nausea to dissipate. When we look at anti-diarrheal agents, so your medication for anti-diarrhea, Pepto-Bismol is probably your biggest one that you guys will hear of, that uses and actually treats a lot of different stomach issues. But management is aimed at diagnosing and treatment of the underlying cause. Why does the patient have the diarrhea is important, and how we treat it. We also want to make sure that we're replacing any loss of fluids, relieving any type of cramping, and reducing the amount of unformed stool. So we want to decrease the amount of diarrhea that they're having. So you have specific antidiarrheal medications and you have non-specific. Specific antidiarrheal medications are the ones that treat specific causes of the diarrhea. So like if someone has an infection, we're going to treat them with an antibiotic. Your non-specific ones, you look at your most common ones as Lamotil and Imodium. They are going to reduce the motility and help not bulk up, but help decrease it so that the body can reabsorb some of that fluid and decrease the amount of times that they're having diarrhea. When you look at other disorders, other types of medications that are used to treat like IBS, and patients with IBS can have cramping and pain with diarrhea and or constipation. They can have a combination of it. Your antispasmodics is dicyclomine. That is Bentyl, a very nice, a very good medication for patients who have abdominal cramping that's not relieved by other medications. Bentyl is very useful and successful in treating IBS for patients. And then other things with inflammatory bowel disease, we're looking at Crohn's and ulcerative colitis. The difference between Crohn's and ulcerative colitis is the location. So Crohn's is usually in the ileum, while ulcerative colitis is usually in the colon and rectum. You're looking at treatment with sometimes corticosteroids like dexamethasone are used to treat it due to the inflammatory process. So by taking the glucose corticoid, it helps relieve the inflammation. Long-term use usually is important, and sometimes they actually end up on methotrexate to treat their inflammatory process. Let's take a 10-minute break and we'll come back and do a review for the final exam.
It's a pain reliever.
All right, and what are some examples of a pain reliever?
Tylenol, Aleve, acetaminophen, ibuprofen.
Yeah, along with your opioid. So your
Dilaudid.
Your Dilaudid, your morphine, those are all pain relievers. Aspirin is a pain reliever. So you can utilize any type of medication, group of medication that relieves pain is considered an analgesic. When you look at aspirin not only is a pain reliever, but it also helps prevent MIs. It also helps reduce fevers. It also helps with antiplatelet, thrombolytics, and with the pain relief. So you have multiple uses for your aspirin. All right. Next, let's see who's next. Tatiana, you get the next question. So what does it mean if a drug is parentally administered?
I think it means non-oral administration.
It's not an oral. It is actually, it's an it's outside of the oral. So you're looking at IV, IM, you're looking at sub-Q, you're looking at intradermal, which is how we give a TB skin test, your transdermal, any type of a lotion that we give, eye drops, any inhalants, your ear drops. You have your different types of patches that we wear. So, oops, that is what that means. So anything administered outside of the mouth, okay, via the GI tract. All right, what's the definition of half-life? Oh, let me see. I got to spin, don't I? Let's see who gets to answer this one. Marilyn.
It's the length of time that's required for the concentration of a substance to decrease, to have like the starting point of the dose.
Yeah. So exactly. So basic way of looking at that, it's the time required for the amount of the drug in the body to be decreased by 50%. So when you look at the half-life, the importance of it is that it helps determine the timing for dosing. So if a drug has a short half-life, then you might require multiple doses versus a long half-life will require less dosing. All right, let's see who's next. Danielle. What is nystigma?
Um, I want to say something with the eyes, but I don't know if that's right. If I'm thinking of something different.
Nope, you're correct.
Okay.
But what is it with the eyes? What do you think?
Don't they just do like a lot of like back and forth movements?
Yep, a rapid
Yeah.
movement. One of the medications that you'll see that with is your dilatin, your seizure medication. Sorry, I moved my PowerPoint slide over. All right, let's see who's next. Maureen.
Okay, an addiction is something where the person physically cannot stop taking it. Like they have to take it no matter what. And dependency is where you need to take the medication all the time. It's where you have to take it. You're prescribed it. Hello? Did you hear me?
Yeah, I did.
Okay.
So when you look at addiction and dependency, addiction is going to be like a physiological reaction. So meaning that it is marked as a change in behavior caused by that biochemical changes in the brain after continuous use of a substance is abused. Substances can be become the main priority of the addiction, resulting in the harm that may cause harm to themselves or others. So it's like they need it. When you look at dependency, the body physically needs that substance to feel good. The video that I attached here actually explains it really well. So take the, I mean, it's like 52 seconds. So please take the time to watch it. and I closed out my circle. So let me pull up my, look at my people here. Let's see. So Brad, I'll give you the next question because like I said, I got to make my wheels spin again. I deleted my names as I was talking, moving around my things. So what is the only second generation NSAID, Brad?
It's a praxillutamide. I can't say that one, but
No, there's only one second generation NSAID. What is it? Does anyone else know?
Celebrex.
Celebrex, correct. Celebrex is the only one that is out there. All right, Candy. What is the fastest route for administration of a medication?
IV.
Correct. All right. Next question, Kaylin.
Isn't this your aspirins and NSAIDs?
Yeah, your aspirin is what this one is. So your signs and symptoms are going to be what?
I just remember tinnitus.
Correct. Good one to remember. So headache, dizziness, sweating. You're also going to see tachycardia, agitation, hallucinations, possibly even convulsions.
Judy, can I ask a question real quickly?
Sure.
I know that we don't really talk about it, and we probably won't, but in terms of the fastest route, how quick is an IO? Is that faster than an IV?
No, it's not. IV is still going to be your fastest route. IOs, they infused, but that's going like through the bone marrow. So then it goes through the bone marrow and then it's absorbed into the circulatory system as far as vascular.
Okay.
So it's not as fast. It's effective, but it's not as fast as your IV.
Okay, thank you.
You're welcome. Yeah, IOs were never my thing to put in. Take them out a lot. Just no desire to shove a needle in someone's bone. Just not my thing. I leave it for the younger girls and guys that like to do those things.
Isn't it a drill?
What?
Don't they use a drill?
Yeah, you use a drill, but I mean, you feel that as you're drilling the IO into their bone, like into their shoulder, into their well, in the military they do the
Tibia.
Well, they do the tibia, but in the military, they're, oh my God, why can't I think of I am really losing my mind today. The chest.
Oh, sternum?
Sternum. Thank you. God. Easy wording. I couldn't come to mind. Sternum. Like drilling into someone's chest like that, because you feel that pop. Because we practice on chicken bones and stuff. You feel that pop into their bone, and that's when you drill a little bit more and you're done. But yeah, you feel that pop, and then it's not a very stable thing. And if you it's just, yeah, you really got to be good at it to do them. And the only way you get good at something is by doing it repetitively. And then when you're like in a trauma case and you're moving your patient and stuff, they're not very stable. So they get moved and then you end up ruining them. And then you got to go do another one. And
oh, okay.
they're convenient for the short-term use. They're not convenient for very long-term use, and long-term being even out an hour. I mean, they're not convenient. They're nice to get in and do what you need to do. And then they basically, if you don't move your patient, you're good. If you move your patient, you've probably dislocated it and need to do a different one. But yeah, if you work in emergency or ICUs, you might get training on them. But if you work a floor, you won't ever get trained on them. The most you'll do on a floor is actually pull out the IO, which is just pulling upward, and it's a pop that you're here. And you just cover it up and hold pressure for a little bit to help No different than when you pull out your IV. Yeah, so IOs are they're interesting. Yes, they're fun to practice on doing, but it's kind of like sticking a needle in someone's back. I just can't watch it. Same thing with the IOs, drilling into someone's bone and hearing it snap. I don't like to do dislocations. I don't like that hearing that popping of the shoulder going back into place or hip. There's just little quirks that as a nurse you'll come up with, that things that bother you. And those just happen to be 3 things that I don't like: epidurals, dislocations, and IOs. Because the sound of bones popping back into place, and ugh. That's why I don't like joint cracking either. Anyhow, let's get back on track. So let's see. Kenneth, what are the 5 categories of drugs for pregnancy?
Isn't that going to be the 5 letters, the A, B, C, D, and X?
Correct. And what is considered safe?
I believe it's just A and B.
A, B, and C. D is considered safe for mother, but not safe for baby. And D or X is not safe for fetus at all. So when you look at category X, it's not safe for the fetus at all. So when we look at some of our category X meds, it's kind of weird in how common these meds are. So like your levofloxacin, your ciprofloxacin, those are 2 common antibiotics that we give, but both are harmful to the fetus, so they're not safe during pregnancy use. Ibuprofen is not safe during pregnancy. That has an X on it for pregnancy category. Drugs like Ativan and clorazepam have X's on them, and not so much that they're harmful to the development of the fetus, but they can cause some, but it's more the withdrawal syndromes that the fetus will go through once it is delivered and is born. So there are medications that are out there that we commonly do use that actually have a pregnancy category X. When you look at D, Ds are going to be some of those medications that are safe to use in pregnancy because the benefit to the mother outweighs the risk to the infant or to the fetus. But your category C, D, and A, those are safe to use. There's not a whole lot of concern with those. The reason the A, B, and C are there is because A has no effect on the fetus at all. B and C might have minimal effects on the fetus, but nothing like your D's and your X's. All right. So Marta, what kind of patient can't receive acetaminophen?
I'm not sure.
All right. Does anyone want to help?
Liver failure.
Yeah, liver damage.
Yeah. Any patient that has liver damage, you want to make sure that they do not take acetaminophen. So your alcoholics are ones that possibly have liver damage, so they shouldn't be taking it. All right, next question. What type of insulin is cloudy? Carrie. That's okay. Take your time. It's okay. So you have short acting, right? You have long acting and you have intermediate. So what would you say is your intermediate ones? So your intermediate ones are your NPHs, which are your cloudy ones. So when you're looking at your insulin, you're looking at the cloudy ones. What can be mixed with your intermediate acting NPHs? What type of insulin? And anyone can answer this.
Isn't it just the regular insulin?
Yeah, your regular insulins can be mixed with it, your short acting insulin. So even your you have your other short acting regular, and then you have your Novolog and Humalog. But always mix clear before cloudy. Because when you draw it up into syringe, you want to make sure that you are pulling up the clear stuff first and then the cloudy stuff. What medication can never, what insulin can never be mixed with the intermediate or the short acting?
Long lasting.
Yeah, so your medication such as Lantus. What medication can be given IV? Raven, how about you? What medication can be given IV?
Regular.
Thank you. When you have patients that are on insulin IV, it's usually going to be a drip. You're going to be checking them every 15 to 30 minutes to an hour to see if you need to adjust their insulin. You will have a guidance on how to adjust, whether you go up, whether you go down, will all depend on what their blood sugar results are at. And then you will see that patients who have DKA, that's one way we treat them is with the IV insulin. What are the other ways that we treat DKA?
Do you want anyone to answer, or are you still using?
Yeah, anyone can answer because we've hit everybody, and I see that students are dropping off of the review here like flies.
DKA is treated with the IV insulin, fluids, and electrolytes.
Yeah. So when you look at the reason for electrolyte replacement is the fact that when we don't have enough insulin in our system, it actually lowers electrolytes in our body. So we need to help replenish them due to the fact that we have that imbalance, because if we don't, we're going to have issues with our nerve muscles and heart possibly. So that's why we not only do the fluids, but we also do the electrolytes along with the insulin. All right. So what are 4 lifestyle changes that we do? Brad.
So, sorry, dogs in the background.
That's
4 lifestyle changes. Obviously there's gonna be weight loss, diet, smoking or quitting smoking, and I'm trying to think what else. So diet, smoking, exercise.
if we have good diet and we have good exercise, what are we gonna have in result of that?
Weight loss.
Yeah, good weight control.
Oh, I guess, yeah. I think of those as synonymous.
I know, but this is how the textbook writes it out: quitting smoking, weight control, exercise, and diet. Now, these are all things that we can modify. Non-modifiable things are going to be such things as our race, our age, our hereditary, and our sex. All right. Sandra, what insulins are not meal coordinated?
Do you need the specific ones or like the ones that are long last or not long lasting? Well, intermediate. Like was it 6 to 12 hours or? Hold on, I'm sorry.
No, you're fine. You're fine. You're thinking out loud. That's okay.
The NPH and the LAMP test.
Yeah. So when you look at your NPH and your Lantus is your long-acting insulins. So any insulin that is long-acting is not given in accordance with the mealtime. Neither is your intermediate acting because they act regardless of whether you're eating or not eating. So they can, if you have a patient who is NPO, you need to make sure that you do monitor their blood sugars before you give them any type of insulin, because you want to make sure that it is warranted, because your short-acting insulins are going to act quickly and you're going to see results. Your Lantus is going to work over a period of time. So if you give the Lantus at 8 p.m. at night, or 8 p.m. at night, because it's usually given at night, and then in the morning, you're finding their blood sugars to be like in the lower 40s, you might need to adjust that Lantus at nighttime in smaller doses because they're waking up in the morning after not eating all night with a low blood sugar. So there is a balance that sometimes you have to find. Or you're finding that you give the intermediate acting ones, and then you go and you give it like at 10 in the morning, and then you go and check them at 4 in the afternoon for their evening dose of regular insulin for their meal, and you're finding that their blood sugars are low then also. Or vice versa, you might need to increase it because they're actually not getting enough of the intermediate or the long-acting insulin. So there is a playing field that you have to kind of pay attention to when you're giving medications, especially like Lantus, because like I said, you'll give it at 8 o'clock at night, but then you get in report the next day that the patient's blood sugar was like 8 or like 20 in the morning, and it's probably because of the amount of insulin they're getting at night and they're not eating. So there is a lot to play with on that. Candy, what are 2 medications used to treat Parkinson's?
Would one of them is levodopa
Correct.
and dopamine.
The other one is your carbidopa. So levodopa and carbidopa. And basically neither one can be used alone because they don't have that effectiveness to cross over the brain barriers. So you basically need both of them to be effective in treating Parkinson. And the main purpose of treating Parkinson with these 2 medications is to allow for the body to function at its normal level as much as possible without that twitching that occurs with Parkinson's, or that shaking, however you want to.
So these 2 are used together at the same time?
Yep, they have to take both in order to have that effectiveness of one of the medications.
Okay.
Maureen, how do we prioritize our care for our patients daily? How do we determine the care for each patient and what order we see our patients?
Well, the order should be the patients needing the most immediate care, like the ones going through just like pain, like immediate care. The lower one should be just like just random tasks you have to do. Okay.
Yeah, and the easiest way to remember that is by doing your ABCs. So when you look at your patient's airway, breathing, circulation, safety, okay? Your patient who is having an asthma attack has airway issues. Your person that is having pulled out their IV. Yes, they have circulatory issues. You can put a Band-Aid on them and move on, but your person with the asthma attack needs attention because the airway is important. So when you look at treating patients, prioritize what needs to be done first. And if it's not done first, it's going to cause bigger problems. So if you can remember airway, breathing, circulation, safety, you should be able to treat your patients. But making sure prioritizing is important in how you see them. Kaylin, what changes do the beta-2 agonists cause? What do we see when we use our beta-2s?
Works on the heart. So it helps, I think, contractility.
Not heart. Remember, your beta-1 is your heart. What is your beta-2?
The lungs.
The lungs, yep, because we have the 2 organs, we have the 2 ovaries, we have the 2 lungs. That's how you kind of remember your beta-2s. So your beta-2 actually is going to help the effects of the smooth muscles causing a dilation of your bronchial passages. They also vasodilate in muscles and like your liver. They have the relaxation of the uterine muscle, and they actually, your beta-2 antagonists actually can cause the release of insulin. So asthma is probably your most common one that you see your beta-2 medications being used in. Like albuterol is one of your short-acting ones. Julia.
This is an SSRI. So if you're thinking short term, you're going to have increased risk for suicide or suicidal thoughts. And then long term, I believe it's increased not risk for like you can't abruptly stop it once you've taken this for a long time. You have to start tapering it off.
Good job. So when we look at safe range for lithium, Tatiana, what is the answer for that?
I'm not sure.
Okay, does anybody know the safe range? Correct. So you're going to see that different labs vary, but for the most part, it's at 0.6 to 1.2. Your concern is when you get over the 1.2 that you start to see the mild symptoms for lithium toxicity, but then you can get to the 1.5 and start seeing some of the severe things for toxicity. I want to go back, Julia, to your question. Effexor is actually an SNRI, not an SSRI.
Oh, that was Effexor? My bad.
No, that's okay.
Oh, yeah.
You're not bad. You said it, and then my head was already moving on to the next question, and I didn't realize that I wanted to go back and say that. 1 second, guys. Sorry about that. So what lab values do you want to monitor on a patient that's taking spironolactone? And what medication group does that fall in?
Isn't that the potassium sparing?
Correct. Potassium sparing, you want to watch for that because it will cause a high potassium, but also it can result in having a low sodium because you have your sodium potassium pump. And so when you are taking spironolactone, it's going to waste out the sodium, but it's going to keep the potassium. Same thing when you're looking at your thiazide diuretics or your loop diuretics, they're going to cause a low potassium. So you want to make sure that you're watching potassium with any type of diuretic, whether it's a elevated one or a low one. Ariana, what is the life-threatening side effect associated with your ACE and ARBs?
Angioedema.
Correct. So the swelling of the lips, face, and eyes.
Can you go back really quick? Sorry.
I will send this out to you guys.
Okay, that's fine. Thank you.
You're welcome. What are 3 side effects associated with an ACE inhibitor? We just discussed one. What do you got for me, Brad?
Bear with me, there's a mailman outside. And they bark all the time. So dizziness from blood pressure going too low, the angioedema you just said, hyperkalemia. I mean, are those the ones you're looking for? You're looking for others? Headaches, dry cough, fatigue, taste loss, all the fun
Yeah.
stuff.
The persistent dry cough is probably one of the more common side effects that you see with the ACE inhibitors that patients complain about, along with, I mean, not along with, but you got the imbalance, you got the low sodium, high potassium, or you have the possibility of the angioedema. Good job. All right. So what test is used for warfarin? What lab value are we looking at? Let me slide down my list. Raven, what are we looking at for the labs used to check the therapeutic level of warfarin?
PT and PTT.
Heparin is 1, warfarin is 1. So which one is for warfarin? Which one do we use for warfarin?
PT.
Correct. And then for heparin is the PTT. So when you look at warfarin, you see the PTT INR, and for heparin, you're monitoring the PTT. All right. Maureen, what are 3 reasons you should hold a patient's digoxin medication? What are 3 reasons we don't give it?
I'm not sure.
Can you give me one?
Um, I'm not sure.
Okay. Marta, can you help her? Or Carrie or Tatiana or Ken?
I mean, there's the irregular heartbeats like bradycardia and stuff, everything else.
Yeah. So when you assess your patient, you should be listening for your apical heart rate. And if it's less than how many beats per minute, you don't give it.
60.
60, correct. And then another reason we don't give it is because we check their lab values and they have a DIG level that's greater than 2 or a potassium level that's below 3.5, because as we know, low potassium levels can cause irregular dysrhythmias. So I will get this PowerPoint out to you along with the other one. So if you have any questions or concerns or need help with something, don't understand something, just reach out to me, okay? Otherwise, I will see you guys next